All right, welcome back everybody to Ultrasound Grand Rounds this week. Pretty excited to be back here today. Just picking up where we left off last week. So if you didn't have a chance to make it last week, we had Dr. Robert Owen from anesthesiology presenting about transesophageal echo in the emergency department and critical care environment. He's obviously in the anesthesia environment, but it translates well to our critical environments. And if you didn't get a chance to watch that, I just posted the video up on our YouTube channel just a little bit ago. So that's up there and available for you to go see and to learn all the wonderful things that Dr. Owen had mentioned last week. And maybe just as a little bit of an aside, before we get into today's topic, just kind of talking about our TEE program. This is something that we stood up a couple of years ago. One of our colleagues who was with us, Dr. Sam Tate, he helped us get it set up, and he's moved on to UC Davis, doing some great things out there. He left us with this program, and so we've been able to utilize this in our critical care environment on the ED for patients who are in cardiac arrest, post-arrest, and in shock. And just this last week, I had a couple patients who were in that peri-arrest period, right, who got ROSC, and we were able to put the TEE probe down, and it was a huge game changer for what we were able to do in the ED. I think we think about this, in the context of, hey, we're doing a test, and does this test have a major mortality impact, or does the patient that it has a major like disposition level impact or diagnostic level impact? And there's some people who are critics around the TEE probe in the ED setting, and what I've found just through my experience in these cases this last week and some other ones is, it may not have that major double-digit mortality change, but really just having the ability to put that in and have an additional monitor on my patient was just a game changer for how we were able to manage our patients and the insights that we were able to bring to bear about what was going on with the patient and what we needed to do and the effects that our treatment were going to have for this patient. And so with that being said, we've been doing this in the ED, we're going to continue doing it. We're pretty excited to have Dr. Owen telling us more and supporting it. And so for anyone in the ED who's interested in learning more about it, just let me know. But it's something that we're excited to do here at Metro in our emergency department. So with that said, we're going to move on to today's topic, which is going to be in the vein, pardon the pun, of cardiac echo or POCUS, but we're going to take a little bit of a different spin on this. We're going to go not transesophageal today, we're going to go transthoracic, and we're going to actually talk about point of care ultrasound for infectious endocarditis. And I know before you get rolling, you're like, yeah, Matt, this is actually a TEE thing. What we want to do today is focus mostly on the transesophageal or transthoracic side of things, because that's what most of the people who are going to be listening to this lecture or are going to be watching it on the YouTube channel, that's what most people have available to them, is the transthoracic echo. And so with that said, let's dive into today's conversation about infectious endocarditis and the use of point of care ultrasound. And I don't know if you remember years ago, we had a short lecture series. This is long before we put things up on YouTube. This is long before COVID. But we had a short series that we did on ultrasound in the IV drug abusing patient, right? And so we talked a little bit about skin and soft tissue things that could happen to IV drug abusing patients. And I believe there's a lung lecture in there somewhere. But one of the big things that we never really got to in that series is this whole idea of infectious endocarditis, right? And it's certainly something that's commonly seen amongst that patient cohort, as well as some other people. And so as we get rolling into today's lecture, let's kind of imagine ourselves at the bedside with a patient. And again, this patient scenario here is completely hypothetical. In fact, I got a comment on the YouTube channel a couple weeks back on our pediatric trace fluid lecture. And they said, hey, how did that patient do? What happened to that patient? What did you do? And it's able to go back and explain, hey, look, you know what, this particular scenario for HIPAA purposes was completely hypothetical, but it represents kind of an amalgam of the patients that we've seen. And so for full disclosure, this particular patient stem was completely made up by me and my brain last night as I was putting this together. But it represents kind of a composite picture of various patients that I've seen in my practice. And I can imagine if you guys have been doing this for any period of time, it would be a composite picture of the various patients that you've seen in your practice, right? So let's kind of imagine ourselves at the bedside in in your hospital, in your department, and you have a 45-year-old gentleman in front of you, right? And the patient has a history of IV drug abuse, right? And they present with fever and they present with chest pain, right? That chest pain is somewhat pleuritic and has been there for a few days. And this is what you've got, right? And this is unfortunately, not uncommon or infrequently seen scenario. And it tends to be a rather sad scenario because there's a lot that's going on in this patient's life. And a lot that just kind of brings them to the bedside here for us in an area where we can really just have that level of compassionate care that they so desperately need. So anyway, 45-year-old, history of IV drug abuse, fever, chest pain that's pleuritic. Look at some vital signs. We get a 110/68, so not horrible, but not super duper high, right? A little tachycardic, 105, respiratory rates 24, satting 92% on room air, right? We got 38.4 Celsius is our temp. And so as you guys are kind of listening to this, as you guys are thinking about this, kind of getting those gears moving, a differential diagnosis is starting to form in our minds. And this is what I like to do with a lot of our trainees is say, okay, you made your presentation, right? Now let's talk about the different things that could potentially causing this. And, I'll push them a little bit and okay, what are the common things? Now, what are some more uncommon things, right? And once we've been able to make that differential diagnosis, once we've been able to put that list of 5-10 things together, now we start having a very clear understanding of what are the next things that we need to do, right? What are the things that I'm worried about, in what order, right? So I can prioritize and execute, and what are the different tests that I need to get to be able to get to the answer that this patient needs, right? And so as we think about this, chest pain, for a 45-year-old gentleman, obviously cardiac is going to come up on the list, right? So ischemic disease is certainly there. PE is certainly on that list, especially with that pleuritic nature of the pain. We could even talk about like a pneumonia that could be potentially causing this patient's shortness of breath, with the hypoxia and the chest pain. But among the things that we need to consider, particularly in this patient, remember the STEM said that it was an IV drug using patient, things that we need to consider are septic emboli, right? And so unlike just a normal, PE, this now has the component of having that infection piece added onto it, which really dramatically changes the ball game. And so that is something that we're going to have to definitely explore, right? And so as we start looking into this patient, we do a bedside echo and we see our parasternal long axis window shows, a little bit tachycardic, no pericardial effusion. We have decent, maybe a little bit reduced ejection fraction. The RV side, I don't know. It's hard to say on this particular window if it's large, but, gives us an idea of what's going on, right? As we go to the next window, the apical 4-chamber window, we see kind of similar things, right? You see decent EF, not horrible, maybe a little bit reduced. You see a little bit of, or no pericardial effusion, and then maybe the RV is just a touch on the big side. I don't know. It could just be a little bit of foreshortening. We'd have to optimize that a little bit. But one of the things you might happen to notice is there is a little something funny going on with that tricuspid valve, right? Do you see that? As some of the beats you can see it well, some of the beats you can't. But there's something extra on that tricuspid valve, and let's zoom in a little bit and let's kind of see that right there, right? And so that is what we're going to find is a vegetation, right? And so as we think about this patient, right, we've now got someone who have a high concern for some, lung pathology because of their SATs. They got that chest pain. We're thinking down that PE versus septic emboli route. And now all of a sudden we find the source, right? And so when you think about patients like PE patients, we're backtracking, okay, where'd this come from? Is probably from the legs. And so sometimes one of the surrogates to be able to get to the diagnosis is to do a duplex of the leg, right? And if they have PE-like symptoms and their DVT study is positive, well, you kind of know where you're going. Same logic applies here, right? You have a patient with septic emboli sounding story. It doesn't mean we're not going to get any further imaging, but all of a sudden now on our echo, we see a vegetation on the tricuspid valve, right? And this is a game changer, right? Because this gets us really headed down the right track early in this patient's care, and not getting us sidetracked down some other little rabbit trails as we kind of explore what's going on with this patient, right? So this is going to be the topic that we want to talk about today. And this is basically going to be get us to prime our brains to start thinking a little bit about how we can bring bedside ultrasound to the patient and apply it in the cases where we're concerned about infectious endocarditis, right? And so that said, let's take a step back, right? Let's back up, get kind of 30,000 foot view, that aerial perspective of the terrain that's in front of us, and really start kind of thinking about what is infectious endocarditis at baseline. And then we can build off of that, of how our ultrasound is going to help us and make that diagnosis. And then what are the test characteristics of our point of care ultrasound as we apply it in this patient? Those are really going to be the outline of today. Like what is endocarditis? What is echo's role in endocarditis? And how well does my echo perform when I'm using it to evaluate for my patients with infectious endocarditis, right? So there we go. That's our outline. So straight up definition, textbook. Let's just kind of be boring at the front end, but at least get us all on the same page here. A definition of endocarditis. And this comes out of the American Society of Echocardiography's comprehensive echocardiography textbook. I'm going to flip back over to my screen here so you can see it. This is the book. We have this textbook down in our office. It's a great resource about bedside echo. Just gives a lot of, it's a great resource about echo in general, but it gives a lot of detail about things. But they have a good couple chapters on infectious endocarditis in there. And so this definition is going to come straight out of this textbook. And they said infective endocarditis is essentially a microbial infection of the endocardium or associated devices implanted in the cardiac material, right? So pretty simple, but think about it, you have your different layers of your cardiac tissue, right? And the endocardium is that inner layer, right? And it's an infection of that layer, right? And we most commonly see it on valves, and it can happen for a number of reasons. And the second part of this definition gets at some of those reasons. But in the advanced and modern era of cardiac care, right, we are now implanting a lot of things in patients. And so just like we worry about infections of various different, types of implants and prostheses and all things, or things like that, also all over the body, it can happen here in the heart as well. And so this is kind of going to be the working idea of what we're talking about with infectious endocarditis. Now, historically, if you think back, it's been diagnosed in a number of different ways, but you gotta think back, okay, years ago, when you didn't have the CT scanners, when we didn't have the MRIs, when we didn't have the ultrasounds, when we didn't have all this advanced stuff, and you really had to go off of what is the patient telling you, and what can you see and hear and touch, and all the different senses that we can bring to bear. And so they came up with these criteria, and these well. This is we talked about in medical school, the Duke's criteria for identifying and diagnosing patients with endocarditis. And years ago, when we didn't have advanced imaging, you had to go off of a combination or conglomeration of some major and minor criteria of saying, hey, this is high probability, this is low probability, mix it all together, and kind of at the end of the day, you get this thing, and well, I think this is probably what's going on, right? And so the major criteria, and this has been updated through the years. So this is the 2000, year 2000 updates of the Duke's criteria. So it's the modified Duke's criteria, and it does incorporate some of these advanced level tests that we do. And so the major criteria is going to be blood culture, positivity, and echo findings of various different, things that can happen in an endocarditis, right? And then your minor criteria is going to be a lot of your clinical findings and your risk factors and stuff like that. And so I don't want to belabor this, certainly don't want to make you memorize it, because who can memorize a chart easily? But it's one of the things that we use to kind of help make this diagnosis, right? And so now let's presume that the diagnosis is made, right? There's a number of different ways of understanding and classifying infectious endocarditis, right? And one of the ways is based off of what the different biological agents are, right? So most commonly, you're going to see infectious endocarditis caused by staph, strep, or enterococci species, right? These are going to be a lot of your skin flora that are going to be the causative agents for your endocarditis, right? So I think one of the things that I read last night, it said about 30%, don't quote me on this one, I have to go look it up and confirm it, but I think like 30% of all endocarditis is staph, right? It's either staph or strep, right? And so a vast majority of them are these agents, right? And we kind of step down to the next tier, it's all those Haycheck bacteria that you learned way back in medical school, right? It's the Haemophilus and the Acinetobacter and the Cardiobacterium and then Eikenella and the Kingella, like these different flora that can be prone to causing infections in the endocardial space, right? And then finally, the smallest group in the bacterial side, and I think the study that I was reading last night, or the source I was reading last night, said about 6% of cases of endocarditis are caused by just other random bacteria, right? So once you get through your big heavy hitters, you have kind of that bucket of all the random ones, and then about 1 to 2% of endocarditis cases are actually caused by fungi, right? So your Candida species, Aspergillus species, so all different things that have a predilection for that cardiac endocardial lining, right? That can cause these infections. And so that's one way of looking at it, right? What is the agent involved? In one sense, in the emergency department, I'm not so hung up on what the agent involved is, because I'm going to cover broadly and then let ID kind of sort things out as the dust settles. But it's one way to look at it. The other way to look at it is, where did you get this thing, right? And so when you break down the causes of endocarditis, you can break them down into nosocomial causes, right? The our fault causes versus the community acquired causes, right? And so the nosocomial is going to be things like, hey, you had surgery on your heart and it got infected, right? You had something put into your heart, you got a pacemaker put in and it got infected, or, you had a heart attack and they did a cath and it got infected, right? So various different things that can cause infections, but also things that can cause endocardial damage, right? So those catheters that you can put in there, or do you have a prosthetic valve, right? That can get infected, or are you on hemodialysis? Like all these are things that can cause nosocomial causes of endocarditis, right? But the bigger ones, at least the ones that we think about, that we see in the emergency department a lot, is these community acquired. And by a lot, I don't mean like it comes in every day. The epidemiology says that, endocarditis represents about 3 to 10 out of 100,000 patients, right? So it's not a ton of them. So we're going to see, a handful over the course of the year in a pretty busy emergency department. But a lot of the ones that, that we're going to see are going to be related to IV drug abuse, right? Because this is going to be one of the major risk factors for someone developing infectious endocarditis, right? And then you can add on to that all the kind of those secondary ones. Are they immunocompromised, right? They don't have the ability to fight off that infection that they need to, right? Do they have poor dentition? That's known to be like a seed for some of these bacteria, right? And then do they have something wrong with that endocardial lining to begin with, right? Do they have some degenerative valvular disease, right? Do they have rheumatic heart disease? Like that sets them up to be a nidus and a seed for developing these infections, the vegetations on the valves. And so it's another way of looking at it. We can break this up in various different other ways. Some people look at it in terms of native versus prosthetic, and that becomes very important for antibiosis and kind of what do you do about it long term in the hospital. But you can kind of cut this pie up in various different ways. But really, I don't want to focus so much on the definitional epidemiology kind of description of that. What I want to get us more pointed towards is, how do we then clinically move to identifying this one, right? Because the mortality in endocarditis is ridiculous, right? So how do we identify this thing? And then how do we start initiating treatment earlier and earlier in the course of their ED stay? Like, if you don't think about it, obviously you're not going to make the diagnosis. But if you also don't look for it, or know how to look for it, or know the characteristics of your test when you're looking for it, it makes your job a lot more challenging. And so that's going to be what we're going to look at today. So there's essentially three pillars to the diagnosis of infectious endocarditis, right? We talked a little bit about the first one. It's clinical, right? You have to just think about it. You have to have that clinical suspicion. You have to have the story that goes along with it, right? You have someone who theoretically has risk factors, right? Who has a story that's consistent with it. They have fevers of unknown origin. They may have symptoms related to it. They may have symptoms secondary to their embolic phenomena, right? Certain one of the studies I was reading, or one of the sources I was reading this week, said that if your vegetation is, I think it was like greater than 5 or 6 millimeters, there's like a 50% chance of embolization. So there's a ridiculous chance that this thing could break off and go somewhere and cause some downstream effects. And man, you can put this on any valve, but if you put it on your left-sided valve, that's a game changer for your patients, right? If you embolize something off your left-sided valves, now you're talking about strokes, infarcts, you name it, can happen. If you put it on your right-sided valve, at least the lungs catch it and you just get yourself a really bad infected PE. And I hate to say it, but at least, but like, man, like the left sided, valvular ones can be catastrophic if they embolize in the wrong place, right? And so your clinical scenario is certainly going to point you towards that definition of or that diagnosis of endocarditis, and you need to have that. It's a sine qua non. But there's also these other ways of making the diagnosis. There's the echo findings. We'll talk a lot about that here moving forward. But then there's that microbiological piece, and this is where you get your cultures, right? And so you have your fever, you have your bacteremia, maybe a known kind of agent that can cause this, and you kind of backtrack the story to get your definition or diagnosis of endocarditis. But that echo is going to be a critical piece in making the diagnosis of endocarditis, right? And so with that said, we're going to move on to kind of talking a little bit about how the echo in general makes that diagnosis, right? And so when I was reading the other day about this one, they said there's two ways of doing the echo on this patient, right? There's two ways of doing echo in general, right? You can do transthoracic echocardiography and transesophageal echocardiography. And we all know that the TEE is the best when it comes to identifying valvular vegetations or identifying patients with infectious endocarditis, right? It just gets the probe right there, right? There's not a lot of skin and soft tissue and air and things blocking the way to make the windows horrible. So you can get pristine views of those valves, and it's really got the highest sensitivity, like in the 90%, right? But that's not a test that's necessarily available to us all the time and everywhere, right? Or at least immediately. You can go to an echo lab and get it done, but at 2 a.m, I don't really have, I got a TEE probe, but that's really not the focus of what we're doing with our TEE program, right? Ours is focused on intubated patients who are in shock, right? I'm not sedating someone to do a TEE in the emergency department right now. And so this is something that's we're going to rely on our cardiology colleagues to make that diagnosis, but they're not there at 2 a.m. They're there at, daylight hours to be able to do that, because they need their techs and they need their equipment and they need their space and all that type of thing. And so today we're going to focus our time on the transthoracic diagnosis of endocarditis, right? And how does this test apply, and what are the characteristics of that? So to know how it applies, we kind of need to know what we're looking for on that TTE, the transthoracic echo. And really there's 3 broad categories of things that you can look for on your TTE, right? The vegetations, regurgitations, and perivalvular extension, right? And so let's talk about the vegetations for a minute, in the regurgitation. So vegetations, and we'll show some slides here in just a sec, is going to be that the evidence, that nidus of the infection on the valve, right? And that's going to be the thing. If you see that, right, you're seeing the effects of endocarditis, or you're actually seeing the endocarditis, right? That collection of infected tissue on that valve, right? Now, that's going to lead to valvular abnormalities, and that's going to allow us to see some valvular regurgitation. And then finally, right, if you get this thing infected enough, right, that's set itself up there, you can get perivalvular complications, right? So you can get some perivalvular abscesses, and you can get, if you have a prosthetic valve, kind of a fistulization around that valve, and so you can get some dehiscence of that prosthetic valve, and so all sorts of other perivalvular things that can be seen on echocardiography in making the diagnosis of infectious endocarditis. Now, this last one is really not the realm of transthoracic echo, right? In fact, the TTE does a pretty lousy job of looking for abscesses, looking for like perivalvular issues. And so that's really where the TEE is going to shine, right? And so we're not going to focus so much on the perivalvular extension as we go through the next couple of slides here. So let's dive into the vegetations, right? Because this is going to be the big key one, right? So valvular vegetations are basically material on the valve, right? And it's material that develops on the valve that as it gets exposed to that, that high velocity blood flow jets that go through, and kind of the damage that can happen to the endocardium on that valve tissue, right? And so by definition, vegetations tend to be these echogenic things that are adhered to valves, right? And they can have, either a pedunculated appearance, or they can have a sessile appearance. They can be of varying different sizes, right? And you can classify them as less than 5 millimeters, or 6 to 10 millimeters, or greater than 10 millimeters, right? So they can be multi-sized echogenic things attached to the valves. They tend to be mobile, right? So as the valve moves, it kind of tends to move decently independent of the valve, if it's kind of just flopping around, kind of attached to that valve. And contrasted from cardiac masses or even thrombi, they tend to have kind of a shaggy, irregular border, right? I don't know if you could say this dispositively as one can, as a binary, differentiation between a cardiac mass, right, a tumor versus a vegetation. But if you're going to point one towards the other, right, you're going to have a more of a shaggy, irregular appearance on your vegetations that are attached to your valves versus something that's going to be more potentially well circumscribed. Border is going to be more of your omas, right? Your cardiac myxomas and things to that effect, right? So that's your valvular vegetation. It's going to be the hallmark finding of endocarditis on your echoes, looking for those vegetations. They can occur on any valve, right? And remember, your patients with IV drug using, or your IV drug using patients tend to accumulate vegetations on the right side of the right valve or the tricuspid valve, right? Because this is the side of the heart that's exposed to a lot of the adulterants and the pollutants that are in the drugs that can happen, that can damage that endocardium, right? Whereas other forms of endocarditis may set itself up on the left side, right? And various different valves. In fact, we recently had a case where we had multivalvular endocarditis, right? And it was kind of interesting, right? The second thing that can happen that we should probably point out is this regurgitation. Now, if you take a step back and think about it, regurgitation can happen for a variety of reasons, right? Anything that causes an incompetence to that valve can cause regurgitation. And so we know that, a prolapsed valve, a ruptured chordae tendineae, a papillary muscle rupture, the myxomatous valves, like they can have, that's not the right word, but the big floppy valves, they can all result in various forms of regurgitation. Even like really bad heart failure that kind of pulls the annulus open can result in regurgitation. So it's safe to say that not all regurgitation is a result of endocarditis, but it's not uncommon for endocarditis to result in valvular regurgitation. So this gets back to those three pillars of diagnosis, right? You kind of need to rely on all three. If you take one out of context, it kind of makes the whole puzzle kind of appear a little bit more confusing, right? And so if you take someone who's got regurgitation, right, especially if you've had an echo in the past and it's acute onset regurgitation, and they have a clinical scenario or a microbiological picture, culture picture that suggests that they have a potential, case of endocarditis, then that goes a long way in helping you make that diagnosis. Maybe it's not the dispositive test. You're still going to probably get them up to the lab to get a TEE done, but it would be enough to say, this is a high-risk patient, right? My post-test probability has gone way up now, and I should probably initiate therapy on this patient instead of sitting around waiting for the morning for TEE to happen, right? And so it's a secondary finding that can happen as a result of the valvular destruction, right? Or the inability to completely close those valves secondary to your vegetations that can happen as in your patients with endocarditis, right? So those are the two big things that I want you to remember. If you're going to take away two findings from today's discussion about endocarditis, it's going to be valvular vegetations, right? Those echogenic things that occur on the valve leaflets that kind of move around, irregular border, sometimes hard to see, but you got to look for them, right? And then the second one is that regurgitation. So throw the color box on, look for your tricuspid valve, put the color box on there, look for your mitral valve, put the color box on there. You can do the same thing with the aortic valve. The pulmonic valve is a lot harder to see. So it's going to be some limitations there in the thoracic echo, but use these tools that you have at your disposal to see if there's something that you can add and bring to bear in this picture, right? So that takes us in the remainder of the time that we have together today to the point where we want to talk about, okay, what about doing this at the bedside, right? And how does this apply to my patient that I have here as I'm doing my bedside echo, right? So POCUS and endocarditis, right? And we talked a little bit about kind of this thing, right? This vegetation, right? And so what we really want to know is, when I do this, what are my test characteristics for vegetations on my bedside echo? And I think, there's not a lot of POCUS specific literature. I have a study we're going to look at here in a little bit that show in a randomized controlled way or an observational way, like what is the exact sensitivity and specificity for these things. And I think if we've done EBM in the point of care ultrasound space long enough, you kind of realize that every test that you have, there's not one specific sensitivity. Like you talk about the FAST exam, they say the sensitivity ranges from this to this, right? And as you do 4, 5, 6 studies, you're going to get 4, 5, 6 different answers of what that sensitivity is, but they should all kind of merge around some common kind of range of numbers, right? But in order to get an understanding of what is transthoracic echo's sensitivity for endocarditis, we got to go back and look at some more of the just general echocardiography cardiology literature, and what do they declare as the sensitivity range, and then we can kind of see what the point of care space is. And a lot of, like I said, a lot of the literature in the point of care space is case reports, right? So they reference some of this basic echo literature and say, hey, we found it here. And they're, like I said, I'll show you that study here coming up. That's point of care specific. But if we think about it, the sensitivity for transthoracic echo, right? Again, out of this ASE book, and it's been confirmed in other places, is somewhere in the neighborhood of 40 to 80%. Woohoo! We had a really good, solid, narrow number right there. But I think what that illustrates is the fact there's a lot of factors that can really affect your ability to see these vegetations, right? And so if you have this patient, you scan them, right, and you don't see anything, there's probably a better than coins flip chance that they're okay, but you're not out of the woods. However, if you see something, then that's where we start getting some helpful information, right? So 40 to 80% sensitivity for these patients with transthoracic echo. And like I said, a lot of different factors come into that one, patient habitus, patient windows, where, what valve is involved is really, really instrumental in terms of what that sensitivity number is. And I think one of the big things is the size of the vegetation, right? We talked about vegetations to be these sessile vegetations, or they could be pedunculated, right? One's going to be easier to see than the other, right? One can be smaller than the other, one can be bigger than the other, and that's going to make it the ability to see it a lot different based on the size. And so, one source basically said that if your vegetation is less than 5 millimeters, which if you look at it, right, it's not much. A centimeter rough correlate is going to be approximately a half an inch, right? Okay, fine. It's 2.54 centimeters per inch. So it's not quite, but you're looking about approximately that. So somewhere between like 3/16 and a quarter inch, right, is 5 millimeters, right? And so this is really, really small, right? And so if you have a vegetation that's less than 5 millimeters, only about a quarter of those were actually visualized on transthoracic echo. But if you break that thing 6 millimeters to 10 millimeters, now you're up to about 70% visualization. You can imagine, the number wasn't reported in the source that I had, but you can imagine if that's greater than 10 millimeters, then the visualization is going to be really good. In fact, another source said that sensitivity for ultrasound, right, transthoracic ultrasound, when looking at vegetations greater than 10 millimeters was about 84%, right? And that's even better than the 80 we just reported. And so you can imagine that as these things get bigger, the sensitivity gets better and better and better and better, right? And so that leads us to this promised study in the point of care space, right? So this study was published last year, 2022, in the Journal of Clinical Medicine. I put the QR code up there if you want to scan that and pull the study and read it itself. But is done in a bunch of Spanish hospitals, right? The article's in English, which is good because we can read it, unless you know Spanish, right? Then you could read it if it wasn't. But it's in English, right? But it's done in these different Spanish hospitals, right? It was a cross-sectional observational study looking specifically at the test characteristics of point-of-care ultrasound, evaluating not only the heart, but other organ systems in patients who have endocarditis, right? So their theory is, hey, look, endocarditis is something that we need to get our hands on, right? We need to get our minds around this. We need to get this diagnosis made, right? It's manifested itself chiefly in the heart. That's what we've been talking about a lot, in this last, 35 minutes, right? It's manifested chiefly there, but it also has extra cardiac manifestations when this thing embolizes. Remember we said, if the vegetation is large enough, there's a greater than 50% chance that it's just going to break off and go somewhere. So there's extra cardiac manifestations in this thing. So how does our bedside echo help in either diagnosing the disease or the extra cardiac manifestations, all to point us back towards this patient has endocarditis and this is what we need to treat, right? And so what they did is they set up this protocol. They scanned the 4 cardiac windows, the typical ones that we do, the parasternal long and short, the apical 4, and the subcostal window. And they also scanned the liver and the spleen, right? And looked for infarcts in either of those organ systems, right? And they did it, interestingly enough, in their methods, they said they did it with a GEV scan, which, if you're not familiar with different types of machines, it is GE's version of a handheld scanner. So obviously the handheld market's gotten to be pretty big over the last 4 or 5 years, but early players in that market were GE among other people, right? And so they had this device that you have a probe on one end, and they I don't remember if that was this device, specifically which version that they had in this study, but I know the GEV scans will have like a dual-headed probe, so you can turn it one way or the other way, and you get different types of probes. And on the other hand, you have a handheld device. They use their own proprietary receiver, not like an Android or an Apple iPhone. So they have their own proprietary receiver that's connected to this thing, but it's all handheld size, right? So they did all these echoes with a GEV scan, which is kind of interesting. It's kind of one of the first studies I've seen with a handheld device looking at the test characteristics of a disease. Usually they're cart-based things. So they did the V scan, right? And what was interesting is it was done by internal medicine physicians trained in bedside echocardiography, but it was done on hospital day 5, right? And this is going to be one of those limiters that was that may affect our ability to translate this down into the emergency department, right? And so they cultured them up, and and 5 days later they did this thing, and I don't remember if it's exactly 5 days from positive or 5 days from drawn, but it was a pretty significant time from the initiation of the patient's care in the hospital, right? But what they found is when they discovered endocarditis, right, they had a breakdown of the different valves, right? And so if in this table 4, they said that about a third of their patients had valve or vegetations on the aortic valve, right? A third of them on the mitral valve, and less so on the tricuspid valve, right? Which is kind of interesting because, they obviously mentioned IV drug use as one of the etiologies, but it certainly doesn't reflect necessarily a pattern that would suggest right-sided, a predilection for right-sided endocarditis. And so there may be some generalizable things here to kind of talk about from an EBM standpoint, but it's interesting just that they went into the level of detail to break down the valves that they had. They broke it down. Most of them were native valves. That kind of makes sense. You get 68%, almost 70% of patients are native valve endocarditis. About 30% are prosthetic valve endocarditis. So, I think it's safe to say it's not like a super heavy, cardiac surgery, post-cardiac surgery cohort. So it's that helps with the generalizability. Large of them came got it in the community versus in the healthcare or the nosocomial space, right? And so kind of sets up the baseline for who these people are. And this table here, table 5, is going to be the key findings in this particular study. And I know it's dizzying, so we're not going to memorize this chart by any stretch of the imagination, but go back and look at the article, pull it, because I think it's helpful. But what it shows is it breaks down valve by valve for vegetations and for regurgitation. What is the sensitivity, specificity, positive, negative predictive value for each of these different, for endocarditis at each of these different, places and findings, right? And so if you look at valvular vegetation as a whole, right, you have your top 4 lines there. Your sensitivity ranges from 50% up to 86%, right? Based on the valve that's being evaluated, right? And interestingly, the least sensitive valve was the tricuspid valve. Kind of surprised me a little bit. I would expect something different. But the most sensitive valve was the mitral valve, right? And so, in fact, they left the pulmonics off. So the aortic, mitral, and tricuspid. And it makes a little bit of sense. The mitral valve is actually really easy to investigate. It's right there. It's in the left side. You can easily get to it with a lot of your windows. So your composite valvular vegetation sensitivity is about 77%, and your specificity is about 94%, right? All of them are pretty high. So I think what this tells us is, hey, look, if you see the thing, right? If you see a vegetation attached to that valve, your dude's got endocarditis, right? There's your answer right there. If you don't see it, you're probably in the right neighborhood, but you're not 100%, right? And it depends on the valve. If you take the composite of about 77% or sensitivity, you're going to have about a 30% chance that a negative study is going to end up having endocarditis, right? And so you still have to consider it. You still have to work it up, but maybe it brings your or post-test probability down a little bit versus if you are concerned about it, you scan them and all of a sudden you see a vegetation, boom, you're done. Like, what it is. The rest of it is going to be further characterization, of what's going on, right? And then if you go down to the regurgitation lines, your aortic, mitral, and tricuspid regurgitation, your sensitivities are going to be about 76%. Your specificities are going to be in the high 80s, right? And I think what this represents is not all regurgitation is endocarditis. And it's not the same thing that you can say about the vegetation. So if you see regurgitation, you got to still think about other things. It's not 100%. But if the scenario is right, if you got someone who shouldn't otherwise have regurgitation, they've never had it before, they've got a fever, they've got these other findings that would suggest endocarditis, and now you're seeing it, wow. I mean, that is probably enough to at least get you going down that route, get those antibiotics started, order up the more definitive testing that you're going to need because you're probably dealing with this thing, right? So that's really, really helpful information kind of as we start thinking through, okay, now how do we use this at the bedside to make these impacts on our patients? And finally, just to kind of round things out, we're not going to belabor this one here. This study also went into these pericardiac manifestations or extracardiac manifestations. And so when you talk about infarcts, the sensitivity is going to be pretty low, 50, 60% if you're looking for hepatic or splenic infarcts, but the specificity is pretty high. So if you start seeing evidence around the body of various different forms of septic emboli, right? Well, there you go. If the shoe fits, it's probably what you got going on, right? So with that being said, let's kind of wrap this up a little bit here. I know we're getting to the end of our hour and we'll kind of want to tie a little bit of a bow on here, but let's go back and remind ourselves, right? When we're thinking about the diagnosis of infectious endocarditis, there's three main pillars in making this diagnosis, and you kind of need all of them, right? One of them will get you started. Second one will get you down the road a little bit further. And the third one kind of seals the deal, right? And so you kind of need you need your clinical story, right? To kind of help set the stage, to give the context for what you're working up, right? And then that is supported by your cultures, right? Your microbiological diagnosis that systemic bacteremia. And it's also supported by the findings on your echo saying, there's my vegetation, there's my regurgitation. Makes the diagnosis of my endocarditis. So that's kind of what we have kind of discovered and unpacked today. And I think hopefully as a result of seeing this, what we can say is that we've learned that echo can be a really valuable tool in the diagnosis of patients with endocarditis, even at the bedside, right? Doesn't mean you're not going to do the other things. In fact, it kind of gives support for doing the other things, for getting the consultative imaging, but it definitely is a huge game changer for patients when you apply this early and start seeing some of these findings early in that clinical setting to help make the diagnosis. So echo is helpful. Echo really can support that diagnosis, but it all starts with that clinical picture. And with that being said, I think we'll wrap things up here. I'm going to cut back to the main screen and just say, are there any questions that we have about this or about endocarditis or things that you guys want to add from your own personal experience, either clinically or doing echo on these patients?
I mean, it seems like ultrasound, like in a lot of other applications, ultrasound is a good way to rule in something, but you can't can't rule it out with ultrasound. But if you look and there's a big vegetation, you're probably barking at the right tree.
Yep.
So it's, very similar to other ultrasound approaches.
Oh, absolutely. And I think that's a great point. And I think just to reiterate, I mean, I know our temptation in the point of care ultrasound space is to say that this one test is the best thing that you can do for your patient. If you do it, it will change everything. It will make every diagnosis and life will be amazing. Right. Well, I believe that's true. for the most part. I think as we gain more maturity, as we do this and gain more experience, wisdom starts setting in. We realize that the limitations of the test, right? And so one of the things that I hope comes out in this lecture, as well as other lectures that we've done over the years, especially when we get, you know, our content experts on, is to say, here's how the ultrasound can apply, and here's how it can make that or help you with that diagnosis, and here's the limitations that you may see when you do this, right? And so, like Sandy said, it can get you there if you see it. If you don't, it doesn't rule it out completely, but it really can help set that pre-test, post-test probability kind of in your mind as you go forward with these things. So yeah, great point. Any other questions, comments, concerns, random musings?
That was awesome. Thank you.
Thanks. Appreciate you guys being here. So I guess we'll wrap things up here, but just a little bit of a, you know, couple announcements, updates. Next week, we'll meet back here, same time, same place. I got to figure out what we're doing. I don't have a topic yet, but we'll make something and it will be good. You'll want to be here. I got some ideas kicking around. The following week is ACEP, right? The American College of Emergency Physicians National Annual Conference. And so for those of you guys who are in the ER, right, we'll be in Philly. We'll see you guys there. If you're not one of the, you know, part of the emergency medicine community, this is one of our big things. We're going to take the week off, right? So we have our ACEP section meeting on the Wednesday before, you know, what would be conference on the 11th. So I'm pretty excited to kind of hear what's going on nationally with bedside ultrasound in the emergency medicine space. And then we'll reconvene on the 19th. And I just got confirmation today that we are going to have a guest speaker on the 19th. So Stephanie Cha, Dr. Stephanie Cha is a physician at Johns Hopkins. She's an intensivist out there. And I was introduced to her by Dr. Shaman, and she is going to be presenting to us about POCUS guided ACLS. So I'm really excited to have a guest speaker on, really excited to get someone on with some, you know, to talk a little bit more about how bedside ultrasound can guide and affect our ACLS decision-making. So hope you guys can continue to join us for this forum in the weeks to come. If you miss anything, we have it over on the YouTube channel. Go over and see that, MetroHealth.org, or not YouTube.com/ and then just search for MetroHealth Emergency Ultrasound. We've been posting stuff up on Twitter. We got some links over there. If you follow us on at MH_ultrasound, EM ultrasound, you can see our stuff there. And then I've been starting to post some YouTube shorts. So go ahead and look over at those on the YouTube channel, basically trying to find little things, normal or abnormal, that kind of are quick bullet teaching points. And so I posted one up this week about vegetations from this lecture today. Got one next week about coming out about the gallbladder, and then one coming out about the kidneys and little stuff. So little short things, takes you about 20 seconds to see it, and you get a little bit of a educational morsel out of it. So all the stuff we're doing over here, pretty excited that you guys can be digging into that. And yeah, we'll look forward to seeing you guys next time. Thanks for joining.